Hello, welcome to the Voyage Podcast. I'm Dr. John, your host, family physician at Voyage Clinics. And today I have David Workman with me, Dr. Workman. He's a family physician and also a hospice director and hospice doc. So he deals with folks in the end of life. We're going to talk about death today. We're going to talk about all the things around it. We're going to talk about hospice, end of life care, and, perception around that space. And so it should be a really fun podcast. I was a hospice medical director in Moab for 4 years, as David and I was talking about, Dr. Workman, and it was really rewarding work. I was delivering babies at that time and working in the hospital, nursing home, ER, clinic. So I was taking care of people in all walks of life, and I found hospice to be as rewarding as labor and delivery. Actually, it was a very difficult, a very sobering time, but also a very beautiful time it could be. Right. And sometimes it's really hard, just like delivering a baby. Like, it's all very, very difficult. There's something special to that time or transitioning, into the world or out of the world. That veil is there's just something special there. And so I found it to be really rewarding work. Dr. Workman trained at the University of Utah. Before that, spent some time at a couple of local universities, BYU, Utah State, and and then did residency. Where did you train McKay.
I did my internship. I wanted a real hands-on internship because I wasn't sure what I wanted to do. So I went to the county hospital in Phoenix, Maricopa County Hospital, for my internship. Just a rotating internship, and it gave me what I was after, which was a lot of experience. I've delivered only about 300 babies in my career, and most of them were during training, a few while I was an ER doc,
Yeah, they drop in your lap.
When the doctors couldn't get there, the OBs couldn't get there in time. But and what you said is so true about the spectrum of life and the different aspects of each phase and the beauty of each phase. I loved how you said that. You did the small town doc, which a lot of guys I trained with up at McKay did that. That was sort of their passion, and a lot of them were from small towns. And I went into family medicine because I was interested in orthopedics and psychiatry and loved delivering babies, but I didn't go to a small town, so it didn't make sense for me to do any of those things except for the kind of the gatekeeper stuff. But I've been involved in hospice for the last 15 plus years, and it's been a beautiful surprise. Just like you were talking about, my impression when I was a young family doc, and then I was an ER doc here in the area for 5 or 6 years full time, and this is back in the 90s and late 80s, and I didn't know anything about hospice. I thought it was, I don't want to offend anybody, but I thought it was, I kind of grew up in the hippie era, so I thought it was a bunch of women in flowered skirts that didn't shave their legs, and it's an incredible service. A beautiful part of my practice has been to be involved in it for a lot of reasons. First of all, it just I love the aspect of getting to be with. Most of them are elderly, but there were some young patients with cancer or other terminal problems. We even had a pediatric practice that they had me involved with for a little while. It's hard, and yet when people start really taking a look at that part of life and the end of life, they start to care about the right stuff, and it's fun to have those conversations. When I went into medicine, I didn't know what I wanted to do until the middle of my college career. I started out as a music major and then served an LDS mission, and then came back. I had been in Washington, D.C., and so I thought, well, got all these attorneys and FBI people, so I kind of did a little pre-law thing for about a semester, and then was installing guardrail in Kingman, Arizona, and thinking about my life and decided that medicine would be a good thing to do. And the two words that came to mind were secure and benevolent. And that was what I thought, okay, I didn't really know much about the medical world besides, watching Marcus Welby once in a while. I mean, I had some uncles who were involved in medicine, but they were in kind of unusual branches. And anyway, I just didn't know what I was getting myself into. But it's been a wonderful experience. And I can't even remember how I first got involved with hospice. But the chance to go into people's homes like we don't do much anymore, it's amazing and just a sweet experience, and to see patients and families in their own setting is very telling, as you well know from your experience, and it's amazing how much they appreciate the idea of having a doctor come to their house and spend some time with them, and it was some of the sweetest experiences of my career have been just doing that, and nothing dramatic that I can think of right offhand, but just memorable, sweet experiences of being in the homes.
Absolutely.
And interesting, one of the perceptions that a lot of people have of hospice is it's kind of the giving up period, and you're going to accelerate the dying process. And you're, I'm sure, very familiar with this study that was done back in 2007, a very good study looking at patients, similar demographics, similar diagnoses, people who were on hospice versus people who weren't. And they studied people over a whole bunch of, I can't remember the numbers, but it was the thousands of comparing people who received hospice care versus those that didn't. And the surprising finding was that people who were on hospice lived about 29 days longer than people that were not. And being involved with it, I can completely understand why. Everybody thinks, well, we're going to give them some morphine, some pills, and they're going to, it's going to accelerate their demise, which is absolutely the opposite of what really happens. And I'm telling you stuff you already know, but in my opinion, a few things are happening. First of all, we all of a sudden become very, very compassionate and generous in their management of pain and anxiety and sleep and things, and people start to rest and get more comfort care, and I think that their rest helps. I think you'll probably validate this, but I can't tell you how many times I've seen people that we take them off of their 10 or 12 medications, and all of a sudden they just come to life, because the
polypharmacy is real. It's real.
And it's a little bit heartbreaking to see that. The work I'm doing now, I work a lot with the elderly primarily, and I'm always looking for ways to take people off of medication, because they're not without their side effects, their downsides, their potential complications. And
Dr. Workman, you said some really cool things, and I want to just highlight a few of them. One of them that I really loved was people start to care about the right things. Yeah. And there's something about that. I noticed it was very similar whether I was in the labor and delivery room with a couple as we're laboring along, or even as that baby is born. There is not a more raw moment of life where we're the most connected to the here, the now, the present, each other, this experience of life. It is just special. And it just scrubs away all the facades, all the things. They're gone. And it's just so real. It is so real. They care about the right things. And hospice is the same. End of life. Everything's gone. All those things, it puts everything into perspective, and it just shapes the people. It shapes the individual. It shapes the caretaker. And it's beautiful. It shapes me as a doctor. I think helping people navigate these very deep, very heavy waters is very rewarding in our lives. It helps us think about the right things and care about the right things. And I think we're lucky to be in a profession where we get to help people in these sacred spaces. And I know it's been very rewarding for me. It sounds like it's been that way for you as well. Yeah. And I want you to think of a couple of experiences maybe that you might share with us that were extra special. I have a whole bunch, I obviously as well, but think about some of those. One of them I recall was like on my residency. Dying with dignity is important. And I don't think the average person knows how difficult death can be and how beautiful death can be. Yeah. And I'm just going to share a brief story to make this point. Two stories. I have a whole bunch. But when I was in residency, I trained at Jacksonville St. Vincent's Hospital, community hospital. We were the only residents there. We were the only physician residents there. And we ran all the codes in the middle of the night, and a code is when somebody stops breathing, stops their heart rate, et cetera, these things. But just for the sake of our audience, I think that it's hard. This person is dying. And so they call a code, and then we rush over there and we run that code. We administer medicines, we delegate CPR, we get all the things situated, and we're kind of running that code. And I remembered running many, many codes that were very difficult. When somebody's admitted to the hospitals, often they're very, very sick. And we often, if they're cognizant, we try to get an idea as to what their desires are. If you die while you're in the hospital, what would you like us? How would you like us to manage that situation? Right. Would you like us to do CPR, do medicines, do oxygen, intubate? There's all these things. And if somebody's like really, really end of life and they have lots of things going on that would, they've got a very bleak life, and it is okay to allow natural death. Yeah. They used to call it DNR, do not resuscitate. Mm-hmm. And that implies that we're not caring about this person. And they've changed that lingo now to AND, which I like a little better, allow natural death. And so you can tell the nurse or whomever, hey, I'm a allow natural death code status. And that means don't push on my chest, don't intubate me, don't give me medicines. If I die, let me pass. And that's okay. Yeah. But that takes some discussion. It takes some comfort with yourself, with death, it takes discussion with loved ones and family, because as soon as that person's unconscious, who now makes the decision for that person's code status? Right. It's their next of kin, their wife, their spouse, their husband. And so they can change it if you haven't had a discussion. Yeah. One incident, it was a long backstory, but I was running a code in the ER, in the ICU. It was an older guy. And codes are sometimes not, they're sometimes very difficult to run. This was an elderly person, very brittle. The chest cavity was very frail, and we were, you definitely break ribs during a code almost 100% of the time. And this person's ribs were extremely frail, and he had liver disease. He had all these things. And so it was a mess. It was a mess. And the family was there, grandkids, all these people. And his wife showed up, and we didn't know his code status. So if we do not know, we have to full code this person. Right. His wife shows up and puts her hand on my shoulder, and she says, "Dr. Sanders, stop all this." And I looked at her with relief, honestly. Yeah. And I said, "Thank you." And we talked afterwards, and she worked the room. So grandkids were there. This guy's children were there. Siblings. I mean, he had a lot of family in the room. This was the South. This was a big family. Right. And she worked the room and loved and talked to everybody and comforted everybody and hugged everybody. And after that code, I remembered going to her and saying, that was really beautiful what you did there. And she says, yeah, I'm an ICU nurse. and she has seen that many, many times. And she knew that her husband was allowed natural death. We just didn't know. And she came in and initiated his will. And that was beautiful. And it took courage on her part. It took, a comfort with death on her part. But I thought that was so neat. And I think we could all benefit from that kind of a discussion.
Oh, I couldn't agree more. And I love the way you described that and the importance of having those conversations. They're not easy to have, but they're so valuable, not only on the back end when you're having to make that decision, but on the front end of having people kind of all on the same page, what's to be done. Getting people all on the same page is sometimes difficult, but I can't tell you how many of those discussions I've had with patients, whether on hospice or in a nursing home or whatever, that where there's, we're all in this kind of fix-it mentality, do everything we can, especially as physicians. That's the way we're trained, and yet it's starting to migrate towards a little healthier view of death. And I've, having this discussion with families, the thing I primarily want to get to is, what do you think your mom really wants done in this situation? Here are the options. We can try to prolong her life as long as we can with, treating things like pneumonia, UTI, dehydration. Now, I'm a big fan of if someone is very coherent and they just get knocked down by an infection and or some reversible thing, and then they're going to get back to being able to communicate with their family and have a good, a good life for a few more weeks or months. I'm all over that, but the fact that we take someone who has no quality of life, they don't recognize anybody, they can't communicate, and to
often can't move,
yeah. and to do things like treating an infection. I love the allow natural death. We're not actively ending their life. We're allowing something that very commonly becomes the ending event of life, like a serious urosepsis or pneumonia or something to do what it does, a fairly rapid, peaceful exit.
It's not a bad way to go, honestly.
Yeah, no,
but it's hard for the average person to consider, okay, mom has been dying for months, and this is finally the thing that will help her pass through.
Right.
It's hard, I think, when we think of, because we superimpose ourselves in that situation. We think, well, if it was me, I would want to be treated for this pneumonia or this urinary tract infection. I can't let mom suffer. No, what we're doing is allowing natural death so she stops suffering, because she's already suffering.
Exactly. Yeah. I can't tell you how many times I've gone into a patient's room and you can just tell they're in pain. They don't know what's going on. They're frightened. And you think, I can't wait for you to get out of here and get on to what's next, because, it's just, this is not fun. And to get, the family to recognize, this is kind of how this typically goes. And we're not doing something bad by not treating something that's treatable, but isn't going to lead to any good weeks or months. I remember having a conversation, this was, 30 years ago, maybe longer, with my parents about my grandmother, who was at that stage, and it's very common for folks at the end of life to kind of lose their appetite and lose their thirst drive, and so they just don't want to eat or drink until they become dehydrated, and so you start having conversations about, well, should we put a feeding tube in and give her some nourishment, and again, absolutely life-saving in someone who has some catastrophic problem that is going to be reversible, and
have a quality of life after.
Yeah, exactly.
Yeah.
And the words that I said to my my parents was, I totally understand you're wanting to do something to keep her here with us and whatever, but it's going to be a lot more painful for you to make the decision to take that away than to not start it. And
that's a good point.
And that's I think is because then you feel like, I am actively doing something that's going to have a devastating impact. But she was at that stage where they just said, well, okay, let's just let her do what she wants. And that's another thing I encourage families. They've got all the dietary restrictions they've been working on forever, and let them eat anything they want.
Yeah.
Anything they want, just enjoy whatever.
Seriously.
Right? And so unless they have swallowing issues, which is another discussion. But
I love this discussion. I think recalibrating our brains to allow natural death is a difficult process because we love and care. And even as doctors, like we are in save mode, right? It's just what we're hard programmed and taught, and we're going to save everyone around us. We're going to do all the things, but then there's an ethical dilemma there, a moral dilemma where is saving this situation the right thing to do? And I think that's where hospice allows you to think differently. It is difficult for the average person to put their head there as well, right? Mm-hmm. Like, gosh, we're in save mode. We want to save mom, save mom, save mom. Well, saving mom might not be very kind anymore, and it might not be what mom wants anymore. And so how can we respect her wishes, not my wishes, and put those first into the mix? That's a hard paradigm shift in our brains as physicians, but also in people's brains as loved ones of these folks that might be passing, to kind of put their head around as well. I used to think, because I was a hospice doc for 4 years, and I watched some really hard things. And I grew up in the country. And in a rural setting in a small town, when an animal got sick or got really, gosh, this animal's not going to make it, right? They broke their leg and they're not going to have a quality of life after this. Right. And you would just put the animal down. Mm-hmm. And I used to think we're kinder to our animals than we are to our humans. And I used to be very passionate and very upset about it, and it would hurt me. And then over time of being a hospice doc, I realized these people stay alive. They're often checked out, and they're often, it looks like they're suffering to me, but I don't think that they're actually suffering. And I think that I've seen the end of life time frame extended with no desire of mine. I was like, oh, this person is suffering. But I've seen that extension help the person who's caring for that person. Yeah. And I've realized that it's not about me and my desires. It's not about other people. It's about that experience for that family. And I've seen caretakers undergo magnanimous changes, like just beautiful, like this is what I needed. I needed this time to care for my mom, even though she was she had dementia. She didn't know who I was. She was bedridden. And she lived for months. And that was for her. It wasn't for mom, who was clearly not there. Right. But it was for those people that were there, coming and visiting and just experiencing that end of life thing. So my perspective on end of life has changed. I'm not a fan of euthanasia or anything like that, but I think it can be a beautiful suffering, if you will.
Yeah. You said earlier a very powerful phrase of dying with dignity, and it brought to mind an experience I had, I don't know, 10 years ago or whatever. I went to visit a hospice patient who was kind of in that real end stage, and they had him out in the living room, and he was on a kind of couch bed thing, and he had some daughters there, and the nurse was there, and he just was restless, and there is this terminal agitation or terminal restlessness that we talk about. But I watched him for a while, and And I don't know if I was right or not, but the thought came to my mind, he wants to be cleaned up. And so I said, I think he wants to be cleaned up and maybe in some clean clothes before he passes over. And I don't know why I thought that, but that was what I thought. And so the daughters and the nurse did that, and he just relaxed and passed. It was really pretty interesting. So I think that we have so many emotions as families, and I'm sure as patients, there's some fear, there's some excitement, there's my parents, my dad was 90, almost 91. He had slipped on the ice and fallen and broken his arm and his hip, and had him in one of the facilities. This was during COVID. It was horrible because Mom couldn't come visit him. She'd have to stand out in the cold and talk through the window. The whole thing was just ridiculous. But he was doing what he felt like she wanted him to do his therapy and try to get his strength back. And luckily, since I was the doctor of the facility, I could go visit him, often, and loved that. But I remember it was actually Easter morning. I thought, he's had enough of this. He needs to be home. And so I went and told him that. Man, he should have just seen the relief and the happiness that he didn't have to be away from family and could be home. And that's a decision that is also part of this frequently, is where do you want to spend the last few days or weeks of life? Do you want to be in a care center, in a hospital, in a whatever, having all these things done, or would you rather just be home with family and comfortable surroundings? And that's also part of that conversation. I think that using that study we talked about earlier to help people say, there's a good chance that they'll be more comfortable and maybe live longer at home in a comfortable setting, being able to rest well than they will here, even with all this fussing that we do. And so
I love it. That's a really, really great point. I think a lot of people think that we have to take our loved ones to the hospital to die, and it's just not true. And that's one of the roles of hospice, is to be able to provide support for family members to help that person die with dignity, allow natural death at home. And it can be really special. I love doing house calls to these folks and peeking in and saying hi and talking to family members, and then allowing and helping that transition to make that more peaceful for them. That's a really, really powerful story and a really great point. I think one of the hard things for the person that might be at the end of their life is losing autonomy, the ability to care for oneself. And, and then at what point do you stop driving, right? At what point do you stop some medicines? At what point do you, do you just shift that gear a little bit? And that's a really hard thing. My wife and I both lost our fathers this last year. And it was hard. It was a hard thing. My dad is a tough old bird, and he's very active, fishing and hunting his whole life, and he's also drank and smoke his whole life. And he's just very active, but he lived a long time. He's 88. Well, he fell in the rocks fishing, right? He was trying to navigate some rocks and broke his hip, ended up in the care center, came out, got real frail, and we see this a lot, right? That if you fall and you're over the age of 65, your 5-year mortality rate is quite high, upwards of 60, 70%. And he was true to form in that space. And a few years later, he fell again, had a compression fracture in his spine, and then did that one more time. And his spine was so unstable, he couldn't stand for more than 30 to 60 seconds. Wow. And it was just monster pain. And so, he's laying at home most of the day. We got home health and services in to help him out. And he lives 7 hours from me and 6 hours from my brother. Wow. And we're the only family he's got. And he's got a brother. He has a brother that's, also old that lives not too far from him. It's his twin, actually. Anyway, so, he's autonomous his whole life and strong and, doing things. And he had to come to terms with needing help.
Right.
And that was hard for him. And we got people in the house and to help him out with food and with things in bathroom. And he's, it's just a hard thing for him to undergo. And then at one point we said, well, Dad, are you getting enough touches here? Do we need to have you in a facility where they can help you more? These folks will peek in on you several times during the day and stuff, but you might need more touches than that. Right. And that was hard because it was just a decline of his autonomy and his ability to care for himself, and then, for others to care for him. And he always told me when he was little, ever since I was little, boy, if I ever end up in one of them damn care centers, you just take me up on the mountain and let the mountain lions get me.
Right, exactly.
He's just old school that way. And so I, I'd go visit him and we'd talk it through, and he's like, no. And it was hard. I watched him waste away. He was not eating because he couldn't get up to, he'd get up and make a cup of coffee and then he'd have to go lay back down. And so, and that was tough. And then one day, he decided maybe it wouldn't be a bad thing. He says, I guess I got to go to one of those care centers. And so he did for a season. And he gained weight. He got the care, a little bit more care, and it was good for him. And so that was okay. And then one day he calls up and says, I'm going to die. Mm-hmm. And see that I saw your eyebrows raise, because hospice doctors all know this. When an old person says they're going to die, they feel it. Somehow they know. And it usually happens within 48, 72 hours of when they say, I feel it in my bones, something's happening, I'm going to die. And they often rally, which is also an interesting phenomenon. We'll talk about that. So he tells me this, and I said, well, okay, well, you could die. That means he's probably going to die in the next 3 days or 3 hours. So I'm like, I jump in the truck and I go up there, and I get to the room, and I just put my hand on his face, and he was nervous. You could tell he was nervous about death. And I just said, Dad, it's okay. And he calmed down, and I said, if it's okay. You did a good job. You're our dad, and you did the best you could. And we had some real tender words. It was really sweet. And the next day, my other little brother comes with me, and we spent the day with him the next day, and he rallied. He looked great. He ate. He probably smoked 10 cigarettes. He hasn't smoked that much in forever. Yeah. And he ate well, and we took him outside and we sat by the tree and we talked, and it was just really neat. We just talk about the squirrel in the tree and the bees and the flowers, and we took him back to his room after several hours of just hanging out, visiting and talking and sharing stories, and he told us to get out of here, boys. You guys get home to your families, and I'll be okay. And I talked to the doc there, and we, got a plan together. And the next morning he passed away. Mm-hmm. we were all home, and I just think that's a story in the hard. So it's hard. It's hard. Losing autonomy is hard, and ending up in a care center isn't for everyone. He would have loved to just die at home, but he said, I need more here,
Well, that's powerful though, Doc, just to hear that story. I love your dad, never met him, but just to tell what kind of guy he is, and to have the gift of being able to spend that time with him at the end, with him being rallying is exactly the right word, and we see that a lot. And then he sounds like the kind of guy that just didn't want to burden anybody ever. Mm-hmm. And so, when my dad was getting near the end, we had him at home, and And he stuck around because he knew Mom wanted him to be there.
Yeah, yeah.
But when he and I were together, he'd say, "Oh, where's the nearest exit?" You know, I mean,
Yeah.
he wanted to be done with all this, and you know, he was 91 then and lived a great life. He was a country boy as well. Grew up out in Vernal and been a fighter pilot and an educator and an administrator. You know, he had a great life, but he, 9 kids and 1 billion grandkids and whatever. Yeah. But he was looking forward to the next phase, and I was really, really grateful. I hope this happens to me, that he was, it got difficult for him to communicate, but he never was really significantly confused. He did have a little episode of delirium after one of his falls and hip fractures, and being in the hospital and things. But yeah, it's hard. I mean, I see my mom, who's 92 now, and she's been a go-getter for 1,000 years, and actually gets to kind of decide. She's on dialysis at home, and she was told when she was young that she would get to decide when her life would end. And she told me right before Dad died, as soon as he's gone, I'm going to stop dialysis and follow him. And that's been 3 years ago. And she's just but she's still very with it. She can't hear very well, can't see very well, macular degeneration and hearing aids and things. But she just wants to be here and do all she can for her kids and grandkids, but she misses Dad terribly and can't wait to be there. So that'd be a hard decision to have to make. I hope that I'm not faced with that. Just, whatever.
Yeah.
Slam into a telephone pole sometime. But
really cool thing you said. And I just wanted to just tell our listeners about this. As people are in the end of life space, they'll have good days and bad days as far as mental clarity.
Oh yeah.
And some days they may be completely confused, completely delirious. And some days they're very, very lucid, and you can have a very, very cool conversation with them. And that was true to form with my dad as well. There were days where he was quite confused. And I was fortunate that when we drove up, he was very lucid the next day, all day. And that was a gift, I think, for us. Yeah. And so I just wanted to make that point that it is very normal for folks to have these peaks and valleys as far as confusion as they enter that space. Having those discussions is really difficult, especially, for family to have those discussions with family. And I would say this is one of the utilities of having a good family doc. I call it a family meeting. We'll just gather the family together, and grandkids, siblings, children, bring them all. Yeah. And sometimes I have it in a conference room instead of an exam room because it gets tight in there when we get to the people. Yeah. And we just talk. We talk it through, and we talk through, losing autonomy. We talk about caretaker fatigue, which I would like to hit on more.
Yes.
But we just talk it through. We talk through, end of life, and we talk about mom or dad, whoever is in that end of life stage, what their desires are. And that way everyone is clear. And there's not some kid or some sibling or some grandkid or somebody coming in and saying, no, we want to do these things to grandpa, even though they don't want that.
It's so hard when you get family members that are opposed to one plan or the other. And it happens a lot.
But it's a good use of a good family doc to just have that discussion, family meeting. Hey, doc, mom's getting old and she's kind of confused and she's got a lot of things going on. And, she's in and out of the hospital quite a bit lately. You think we could have a family meeting with you? Like, that's a great use of a family physician where we're used to having those discussions. We have them all the time. And I think it's something we don't often think about ways to use our doctors. But it is very appropriate and very, very good to just talk it through.
That's such a great point because with the discussion and everybody able to bring their feelings to the table and talk about them, I haven't had very many situations where you couldn't eventually get everyone to kind of realize that, okay, yeah, we all want the same thing here, and we want what mom wants or dad or whatever, and so you're right. That's such a powerful use of some time and a family doctor, and it doesn't happen enough. And when it doesn't, and there's conflict, that's difficult for the family and sometimes for the patient. But
there are some forms that people can have filled out with their doctor as well, just to delineate what they want. And it doesn't have to be allow natural death or full code. There's some in-between spaces too. Like, it's okay for you to do compressions, medicines, but I don't want to be intubated. Like, you can delineate that very specifically on forms. And so, again, another reason to talk to your doc, or even as you enter the hospital, have a discussion with the nurse and the caring doctor for you there. And I think that's important, just to advocate for yourself in this process of dying with dignity. And is that okay? And being okay with that.
Right. You're right. Trial of IV fluids, trial of antibiotic. There are lots of different areas. But then to have people realize that, hey, this form is really important, so know where it is and know kind of what it says. So if you can tell the paramedics that show, whatever. So, or the staff in the facility. Of course, the facilities, they have to have that figured out in the chart. But, but now
I want to talk a little bit about Day of the Dead. I think it's a beautiful culture. I'm half Mexican. I have family in Mexico and stuff, and there's the Dia de los Muertos, or the Day of the Dead, and I think that's really a beautiful. I think it's a beautiful tradition and celebration around death. It is a celebration, and they have parts for the jóvenes, right? The young people who have died, and then they have another day for animals, actually. And so, and then they have, for all the rest of the people. And they celebrate these days, and they dress, they paint their faces like, skeletons and things. And it's, I think it's so healthy for the young people, for the old people, for the whole culture, for the whole community to have just an acquaintance with death and a respect for it and a celebration around it. Often I see a lot of fear in our culture a little bit, and I see anger, and some of these are grieving and things, and they're super normal. But sometimes it's really hard when folks are like having a hard time with allowing someone to die. I think it comes from just a concept of death that sometimes is hard. It's there's a lot of fear around it. And so I don't know. I think some of these traditions are really cool to implement better thinking around the death and dying. And, is it okay? Are there certain books or anything that you would recommend folks kind of think about or consider, or anything like that?
Wow. Good question. I have seen some floating around, and I can't think of the titles right now that are often used in the hospice space. One thing I really like about the hospice service as well is how many people are involved in that that service. I mean, it's not just a doctor or a nurse. There's aides. There's spiritual support from chaplains if you need that, or the social workers who kind of can help with anything that they do. But I've had so much fun being involved with some of these hospice teams. They're just wonderful people. You have to be a certain kind of person to be involved in that, and you don't have to wear a flowered skirt, and you can shave if you want.
I love that you said about the team, and I think a lot of people don't know this. So there's a physician, there's nurses, there are aides that come out and help with anything that people need, from cleaning to bathing to all kinds of things. There's a chaplain, somebody that's religious in origin that can help you with whatever religious needs you need. A social worker to help you with the mental aspect of that. Maybe you need some talking, some therapy things.
Yeah.
We had a music therapist as well who would come out and play the harp and visit with them. I think hospice is so neat. I mean, there's so many services that they can offer that, it's really good.
Probably some of my, I can't believe I forgot this, but some of my sweetest experiences, I played the cello. I used to take it into these facilities, particularly at Christmas time, and play for a little while. And I had, I don't know, 3 or 4 experiences where it just felt right to take that to a patient's home and just sit in their living room and play for them. And fortunately, I don't have to haul a bunch of music and if someone's got a favorite song that I actually know in my head, I can usually pick it out on the cello, which is fun. I remember one guy who was a crusty old boy, and he asked for Amazing Grace, and I had never played that, but it turned out really, really all right, and so his family asked me to play it at his funeral. His service he was a Mason, and so I'm going to sit there in his backyard with a bunch of Masons lined up here and play that was so yeah, music is such a powerful part of what hospice people do, and there's something about it that nothing else can quite match, as far as the peace and just the depth that it can bring to people's experiences. And we talked about earlier, people start caring about the right things, and that helps kind of steer that in at certain times. But yeah, I've forgotten about it. I had some amazing experiences. Yeah,
music is so good. Well, Dr. Workman, thank you for spending some time with me today. And
fun.
It's neat to hear your, expertise in this space. You've been doing this a long time, 15 years doing hospice and stuff, and helping people pass on. That's great. I think we get really comfortable with it, and I because we see it a lot, and we help people navigate these waters a lot. Most people are not comfortable with it. So my intention with this podcast was just to bring it up, talk it through. That way folks can start being a little bit more comfortable with it. Yeah. Just last week, I had a patient, it was last week, he passed away. And love this guy. Just a wonderful, wonderful guy. He had end-stage liver failure. And about a week and a half before he passed, he and his wife came into the office, and I kind of felt like we needed to have a talk about end of life. What would he like, and what did he want? If he were to go to the hospital really sick and, code, his heart were to stop or he were to stop breathing, what were his wishes? And at first it was really hard. It was hard to even, he cried, wife cried, and we kind of but I knew it was a discussion we kind of needed to just talk about. And it was neat to hear him express his wishes and his wife to listen, and for them to talk it through and to hold each other and to cry together and to just mourn the situation. It is a hard situation, and it is okay to grieve that. And then the very next week, I think, was when he went into the ICU, and passed away within a few hours. Wow. I talked to his wife, and she says, "I'm so grateful we had that talk. I knew he didn't want to die, but right. I knew how he wanted to die if he did die." And I thought that was so cool. It was just so cool, so special. Yeah.
It's a difficult conversation to have sometimes, or at least to initiate. And usually once you're into it, it becomes a beautiful, very rewarding experience. And people are incredibly grateful to to have that conversation. So I'm impressed that you do that so well with your patients, because it is a topic that we sometimes avoid, and I guess understandably, but
it takes time. It takes time, and it takes effort, and it takes gumption. Right, it's tough. It's not an easy thing.
No, it's not.
Yeah. But yeah, we were able to spend some good time on it and talk it through and just help pour some peace into the situation, for the following week. So it's kind of neat. But thanks again for your time today.
You.
This was so special. Yeah. And I hope our listeners learned some good things. And this is just a really special topic that's near and dear to my heart. Helping people into the world is beautiful, and helping people out of the world is beautiful. And thanks again, Dr. Workman. I appreciate your time.
You.
This was super fun. Okay, thanks, Al.